But as a community practitioner, when you are in these communities and you mention SHA or SHIF, the first thing that comes to their mind is NHIF. And the second question is, hiyo ni nini? What is SHA? What is SHIF? Ni nini hiyo? They do not understand. And that points at one thing that didn't happen with SHA, creating awareness and public participation, which the courts mentioned. Even though it was done, and we know how our parliamentarians do public participation, notice come to civil society organizations that are government friendly, and you are given less than 2 days to prepare and then make an appearance at the parliamentary committee. Barely will say nothing, because there's a new law that you don't even understand in the first place and what it's supposed to mean to communities. That is one area that has really done the communities a blow. Now, if I'm to pick from lessons of UHC pilot, those people who engaged or interacted with the pilot phase of UHC, I had hoped that as government they'll pick lessons that were there. One, the pilot phase actually did not eliminate out-of-pocket payment completely. At the point of entry, that is what it did, but at the wards, you were being sent out to go and buy things for you to be attended to. What is happening currently with, or used to happen with Linda Mama, tutakutibu bure, but go and buy ABCD. That was also a gap. Another gap was on human resource for health. There was an influx of patients, but then there were less health professionals to attend to them. Now, these things angers communities when they go there. They'll tell you, I remember when we used to work, and we still are closely with KMPDU, I used to tell them, come to communities. People are angry with doctors. Anybody in a white coat, whether a doctor or not, to them is a doctor. And when they are asked questions at the facilities, they shy away and go. And that is how they go to private facilities when they are holders of NHIF or SHA. Another thing with private healthcare provision was that I don't know how hospital empanelments are done, but even in ghettos, in very poor low-income areas, you will see a facility written NHIF accepted, a mabati somewhere. You're not even sure whether the person you're seeing inside there is a doctor in the first place, or whether you'll get quality healthcare services provided for. But somehow NHIF was reimbursing these kind of facilities. So this is what Wakili mentioned here. A lot of public funds are moving into private hands. I don't want to mention some facilities, but you can all see it's all out there. There are facilities that just mushroomed from a one-bedroom house to a flat. And that begs the question, how many poor people are they seeing using public insurance card? Because during our research on NHIF then, we realized 65% of NHIF money was actually flowing to just 3 facilities, private facilities, big hospitals, which are not seeing any poor person. So it means poor people are paying for people who are able to pay for their health insurance. Now, this as an activist have usually angered me, and I've always been asking myself, how do we make communities angry? Because when votes are stolen, everybody comes out. Everybody. Even the person who don't know how they were counted comes out. But when there's news that money has been lost at KEMSA, they don't know the impact of that on them in terms of access to healthcare. When PPPs are done, like the big mess, you remember it, where government goes into contract with private companies, and then money is siphoned out of Kenya into those. They don't even know how that impacts them, and we know up to now there are facilities that have those equipment and have never used them, and they don't even have expertise to operate them. These are the gaps we have, and these are the things that denies community people to access quality healthcare. Another thing I wanted to mention was, even with the Rwanda case, we can use the Mijikumi like Kagame did. They borrowed the Mijikumi idea in Kenya, and we have all the data. We have the Huduma number data. We have all the data. Government knows everyone. Then use the data to publicly pay for those in poor households, and then charge those who are in employment and those who are able to pay. They spy on our M-Pesas. They know everything. Then we have moved more people into the scheme, so that now we start the debate when they are there. Because even those who are in chief now are people who have been transitioned from NHIF. Why is there low uptake from communities? That is a question that should be asked. So as Wakili said, we just need to go back to communities, make them angry, and make them demand for healthcare service delivery, as my sister did. Clear. But one thing that Chief Act really missed on was defining what emergency care was. And this is a big gap for citizens. She shared her experience in an ambulance. So ambulance service should be part of emergency care, if you ask me. And that is what actually fails many people from community level. Number two, I just wanted to ask, Prof, is there a way we can increase the money the national government remains with, under the Ministry of Health remains with, the 65%? Can we devolve more, because more functions are with counties? So what are they doing with 65% of health allocation at national level, yet services are at the devolved level? Another thing I would really discourage now that Trump has happened is over-reliance of donor to fund our programs, like HIV programs and so many programs that are now going to be impacted on. And I think national MOH does this deliberately to counties, because they know donors will go there and they will cover those programs. Another thing I would want to mention is the biggest problem we had with NHIF was its inability to interrogate bills that comes to it. Will SHA, now that we have SHA, will SHA have this capacity? Because that is where a lot of money shifts from public into private hands. And lastly, I would want to say, even this SHA shift discourse is within urban centers. What's happening in rural areas where the majority of Kenyans are? What's happening there? And lastly, insurance-based model, Prof, in my opinion, is not the best way to achieve UHC. It will expand space for private players and come to what Wakili was saying, commodify, commercialize, and marketize healthcare. Thank you.